This is the Owens Recovery Science Podcast.
After watching all those videos pre-jazz, I'm supposed to clap so you know where the sound comes in, Kyle. Where you see that spike, you'll know. After all that shit we did jazz and probably got nothing because of the damn ice machine behind me.
Yeah, it's pretty brutal actually. Yeah, ice machine. Slime in the ice machine at the Utah. Not really. That's you guys don't know that, do you? Do you know that, Ben?
What?
You might, being from Houston kind of region. Slime in the ice machine. You don't know that? There's this legendary so there's this legendary newscaster in Houston. He's passed on. His name was Marvin Zindler. And every Friday night he would do like health reports on restaurants around the Houston area. And he always had this bit, slime, when they found slime in the ice machine, they'd have like graphics and it'd be like, slime in the ice machine. And everybody would,
big slime rolling
tune in Friday night after the football games, the high school football games, to watch Marvin Zindler's health reports on Houston area restaurants.
That was Kyle's boring ass Friday nights in high school. The slime in the ice machine.
Exactly.
Put on slime.
No, we have to watch this. Yeah.
All right.
Exactly.
Welcome to another Owens Recovery Science Podcast. This is Johnny Owens. I'm here with the crew: Ben Weatherford, Kyle Kimbrell, and Zach Gunkel, who goes by HMFIC. I'll let you figure out what that is. I'm El Jefe, Don Juan, the real HMFIC, Johnny Owens. I roll.
I thought it was Arch Manning's fanboy.
I've been that, man. I just really am now. So if I can get an Arch jersey next podcast, I will be rocking that bad boy. An Arch helmet, whatever it takes.
Man. Shout out all our listeners with Texas Longhorn football connections. Please send Johnny a Arch Manning.
Our buddy over there, Donald Wynn, doing great work.
Ranked number one.
Let's get those guys fixed. Donald, dealing with an abdominal strain with Quinn, but we're good, man. We're golden. National champions for probably the next 10 or 15 years, I'm thinking.
Sounds about right.
We're going to beat ULM this weekend, probably. It
sounds like Johnny's been drinking what Sark quit drinking.
This is like how every season starts. Just ride that high, baby, until it.
I'm always like, we just won recruiting. Did you see that recruit? I don't even worry about this.
Texas Longhorns, the new Dallas Cowboys.
We'll buying up my tickets. Got my Kentucky tickets. So
Hey, they almost beat Georgia.
I know.
Better be careful. They almost beat Georgia.
Fell apart against South Carolina. I know. We have Georgia in like 3 weeks or something. So we'll see. Georgia in town and F1 Austin. It's going to be a nightmare.
Oh, the same. Oh, wow.
Same weekend, yeah.
Brutal. Are you going to F1?
I'm going to make it. No. Man, that's a pricey sport. I don't know if you guys know.
I don't have any idea.
I dropped some serious dough last time, but we'll see.
They have a hole in Vegas where they did the, like, I think the main hub where they take off and finish from or whatever. Like, they got a huge plot of land that's just dedicated to that. Right off the strip.
That was a whole shit show in Vegas for Formula One.
Yeah,
dude, it was a disaster, man. Like, the road was all messed up. The drivers were pissed, and then the
manhole coming up through the Ferrari.
Dude, it was nuts. And then, like, the Formula One people wanted to control the viewing so that people in the high-rise hotels couldn't watch. So they had like these black walls going up, dude. It was a mess in Vegas.
Yeah, I'm gonna let them figure out Vegas before I go watch that one, because then the damn race was at like 3 a.m, which I would either be passed out or drunk or both. So they gotta get their act together in Vegas before I drop that watch. All right, man. So any housekeeping stuff? A lot of stuff coming up. I'm speaking at the Human Weapons System virtually on Friday. I've got the Defense Health Agency talk in a couple months. Society of Orthopedic Military Surgeons in a couple months. We're doing the Kansas APTA in November. All sorts of cool stuff going on here. You guys, Z, you got that one that
Mark
military
Magnago.
one.
Oh yeah, that one. But then Mark Magnago and I are doing the Neuro Academy conference this weekend in Columbus.
Oh, sweet. Nice, man.
Oh, in Columbus, Ohio?
Yeah.
Nice. I went to Columbus in May. It's a cool little town. Where are you staying? Are you staying downtown or?
Yeah, I mean it's at the Hilton. So
okay, nice.
The conference is. So
is Mark teasing any new data?
I think we have some stuff, and then we also have a perspectives paper that has been accepted in the PT journal. That should be pretty good. It's neuro specific, and I don't know when it's going to be published. We were hoping it was going to be published prior to this conference, but it's been fully accepted. It's just waiting on publication now. So
nice, man. Well, Mark's good people, man. Tell him we said what's up.
Yeah.
Anything else, fellas, before we get into this paper here? All right, we got a kind of spinning off of, other than ortho, Z and Mark doing all the neuro things right now and good stuff. This paper is other than ortho, and it kind of piggybacks off of our Annie Bain talk that came out, 2 episodes ago, I think, Kyle?
Yeah, 2 episodes ago.
Dr. Bain with Parkinson's, and that's a badass podcast. She's so good and so smart. And one of the things she looked at was changes with BFR in Parkinson's patients to their vascular systems. And, I threw out at the end, man, I think the potential of BFR on the vascular system can be huge. That could be something that, I feel like could be Medicare code worthy if we keep getting papers that show potential. And it's all pretty straightforward, man. These protocols are like, 4 to 6 to 8 weeks to see changes in the vascularity. It's either like walking or just doing a simple exercise. So not super complicated, kind of low-hanging fruit here. And so the paper today that we're going to go over is actually looking at peripheral vascular disease or intermittent claudication and blood flow restriction. So it's from Parkinson et al. The title is Low Intensity Resistance Exercise with BFR for Patients with Claudication. And it's a randomized controlled feasibility trial. So, what you can get out of that title right there is this is the setup where they're hoping to get a larger multi-center, it sounds like. So this is a feasibility trial. So they want to see, is it safe? Is it tolerable? But then also, lucky for us on this one, they measured some outcomes, which were pretty impressive. And so again, it's in the Vascular Medicine Journal. So went into, I think, kind of a good home journal for them. What they took were people with peripheral vascular disease I've been working on this all morning, the Sheffield Vascular Clinic in the United Kingdom.
Oh boy. Oh boy. I don't know. Johnny, are you there?
Send that,
I don't do not like
oh boy. I think you're having internet trouble again.
Sheffield, where they eat chips and fries or whatever they call it. Fish and chips and fries. I get a reputable vascular disease. Terrible pub food. So anyways, they used the Sheffield Vascular Clinic feasibility trial. So it was 30 subjects. 15 did blood flow restriction, 15 in the control group. And again, easy protocols. So it's 2 times a week for 8 weeks. And basically 2 exercises. They did leg press or leg extensions at 20%, right, fellas? 20% of a 1 RM. I didn't write that down. 20% of a 1 rep max. They followed the standard protocol, 30, 15, 15, 15. And they used a Hokinson device, 13 centimeter. It's pretty wide cuff. That's what we used originally in the DOD. So these big vascular tourniquet systems at 50% limb occlusion pressure. And so that's something that's kind of been consistent in some of these vascular papers is using a lower limb occlusion pressure, which I think when we talk about some of their outcomes, maybe why they didn't see changes in muscle size or strength. I don't know if maybe this LOP is something with that to discuss. But basically, two groups. It was work match. The control group did the same thing, just without blood flow restriction. So first primary outcome is feasibility. So can you get people who have poor blood supply, who have difficulty walking distance because of their poor blood supply and claudication? And I guess we should kind of set up the stage here, and you guys chime in. Peripheral vascular disease is a disease, obviously, of the vascularity, where with this claudication, when you do anything that requires ambulation or effort, the lack of blood supply can really start to cause a lot of pain and reduce function. One of the biggest treatments is just graded exercise. There is actually, I've been told, a Medicare code just for monitoring peripheral vascular disease patients walking on a treadmill and trying to see if they can increase their walking times or doing resistance exercise. But it's very difficult. And we were trying to get a study going with some vascular surgeons at Walter Reed, and they said these folks just really have a hard time sticking to exercise programs, primarily because they start to have so much pain. They just can't really get through the effort. So the feasibility piece of this trial also is, well, BFR is low load. Is this something that would be tolerable and also give these folks some positive outcomes? So on the first outcome of feasibility, they had no adverse events, which is awesome. And, you know, we have always heard, especially in the early days, well, this BFR stuff reduces blood flow. So conditions where you don't have blood flow, it's probably going to be bad for those individuals. We've even heard it said, you know, kind of thrown out, and just kind of roll my eyes at it. Healing of structures like an ACL or a tendon, it's going to limit the healing response. And, you know, I think we all think it could be opposite, and we'll get in deep of why we think it really helped these patients. But no adverse events. The adherence to the program was 80%, 81% total. So 78% of the BFR subjects were able to do it. 84% of the controls were able to do the program. No difference between groups. And the completion rate was 90% total. BFR, 93% of them completed it all, and 87% of the controls. Do you guys have any thoughts at first on that primary outcome of just, was it feasible? And, you know, I know we believe in this, but any concerns initially on peripheral vascular disease doing blood flow restriction?
Concerns? No, I can't imagine.
Yeah,
what we would be concerned about.
I mean, I think for me, it's always been the fear avoidance side of things, of we don't really know. And then, you know, for us, it's always been the, you know, at least internal joke about intermittent claudication and the walking program. It's like, well, you know, they're kind of already getting the feelings of BFR with walking. You know, do we need to add something to that? And, you know, who knows, because we haven't really seen it done. So,
but since they have such a limited blood flow supply already, just taking the rest of that blood out, was there any thought that maybe they just wouldn't even be able to complete, you know, do 75 reps for two different exercises? So 150 reps with, you know, they're almost maybe at an IPC point, even though, you know, you're letting.
I think we have like a really poor understanding of how these people recruit muscle and use muscle when they engage in activity. I mean, if you go back to our podcast with Jamie Burr, there's a great clip from that where he starts talking about diabetic muscle and how it just goes anaerobic straight away, which is why they fatigue so fast. Yeah. So the problem that you're going to have with these folks that have intermittent claudication is not like this just happened overnight. So you have months and years of reduced activity, you know, increases in stasis within the vascular system, you know, lack of use of the muscle, which is going to cause those fiber types to ultimately shift more anaerobic. And so now you have a crew that doesn't even bother even trying to use the aerobic system to produce energy. They just go straight anaerobic. So I think this is where BFR, you know, provides kind of this novel sort of stimuli that sort of forces you to, you know, engage that aerobic system a little bit by just stressing it in a different fashion. Those are my thoughts.
Right. That's always the key point. Everyone thinks BFR is just anaerobic, and it's not. You know, you definitely get both fiber types, and there's been biopsy trials and all sorts of studies that have shown that. So it's not just an anaerobic thing. What do you think, Zeke?
Yeah, I mean, I think, you know, something I'd say with Kyle's thought is I think maybe one of the challenges is if that muscle fiber is not getting oxygen to begin with when you exercise, the potential would be if we're going to tap into an aerobic type of an effect, we have to do something to shift us in that equation because it's a matter of the blood flow not getting there type of an issue. And then I think the other thing that you see potentially as maybe a benefit is the stuff from Danny Christensen and what he talks about. He talks about it more on the performance side of things, but it's this ability that BFR has to buffer um, this metabolic and metabolite buildup, and we buffer hydrogen, and that way we're able to exercise or perform for an extended period of time. I think that potentially could be an avenue there with them.
What are the, I don't know, none of us have probably worked a ton with peripheral vascular disease. What are their contras to exercise? Is it just pain? Do y'all know?
I don't know off the top of my head. I know in the Australian guidelines,
The guidelines, yeah.
in that Australian guidelines, it's exercise. It is the treatment, and then the advice is progressively increase exercise. And I think with that, you're not running into um kind of like a blood pressure type of an issue or something, kind of that would limit your the ability to perform exercise or partake in exercise. It's self-limiting.
Yeah.
Yeah, and that
Which again,
that position stand paper that you're talking about, Zach, it didn't really give any specific contraindications. It just said to do your due diligence and screening on the front end, do some exercise testing to determine a baseline, make sure you're checking blood pressure and heart rate to assess somebody's baseline and monitor throughout treatment. And then, yeah, like you said, the guidelines are basically to try and work your way up to the generally recommended guidelines for exercise for most people, doing your 2 to 3 days a week of aerobic activity up to 40 minutes, probably starting with less, working up, doing at least 2 days a week of resistance exercise, but targeting more like 3 days a week and doing, multi-joint exercises, especially targeting lower extremities. So, I mean, it's pretty much, they're like, we want everyone to be working toward general guidelines for exercise here. And
so just do as much as you can until you can't, and pain stops you, or you just can't go anymore, basically. So again, really no fear of putting a tourniquet on these people.
Which is basically what you do with exercise, no matter who you are, right? I mean,
there's nothing real novel there.
If you exercise, that's what you freaking do.
Yeah. The only real novel piece in that position stand paper is the guidance on intensity based on the claudication pain scale for their walking. And it's like, 0 to 5 scale, walk at a 4. And that's your guidance. And if you can't walk at a 4, walk at a 2 or 3. And, it's basically like do what you can. And, maybe you're starting at accumulating 10 to 20 minutes of walking in a session, then you're trying to get up to 40. So it's, it's either that or you can do an RPE based, resistance exercise at times. But again, there's nothing really that different about what they're recommending. It's just using a different graded way to get there.
Okay. Well, so
I think that's how we look at it. From a BFR perspective, I mean, that's kind of how we are looking at what we're doing. The addition of aerobic exercise, the intention is to stress the vascular system and the cardiovascular system, and that's all we're trying to do with BFR is provide a stressor to that system. We're just providing it in a more localized and probably, in some respective specific way. So, we have options with BFR or just ischemic preconditioning to grade exposure or stress in a manner that not previously even possible. So that, from that perspective, I think it's pretty cool to kind of think about how BFR might influence these folks in terms of their outcomes, or BFR/IPC, if you will.
Well, 100% in this first feasibility study, they had no issues with them being able to do it, it looks like. So real high compliance, we're able to get through it. And then let's look at their objective measures that they took. So 6-minute walk test, time to claudication, pain, their change in their quality of life through self-assessment, and then changes in vastus lateralis size and MVC. 6-minute walk test, I think this is pretty impressive. 86% of the patients in the BFR group improved their 6-minute walk test distance by greater than 35.5 meters, which represents a large clinically important difference, although I saw some other papers that maybe that was on the lower end. At follow-up, and only 33% of the patients in the control group were able to see an increase. So almost 90% of the BFR group increased by 35.5 compared to only 33% in the control. That seems pretty sweet for twice a week for 8 weeks. The time to claudication was prolonged in the BFR group by 44.7 seconds after the intervention, but not in the control group. It only increased by 2.6 seconds. So significant in the BFR group, not the control. And that seems like a big difference between the two, almost a minute compared to just about 3 seconds. Pain ratings in the 6-minute walk test were reduced in the BFR group by 1.1. And it was significant compared to the control group, which is only negative 0.3. Their quality of life was significantly improved in the BFR group. So scores reduced in 4 out of the 5 dimensions. A reduction is good in the outcome measure they used. So 4 of the 5 were reduced. And overall, there was an increase in their self-related overall health. They did not see that in the control group, but only 1 dimension that had score reduction. And then the thing that did not change was vastus lateralis size and MVC. And we can talk about maybe why that might have not occurred. So they didn't see change in muscle size or muscle strength, but they did see improvement on all these other functional measures. So thoughts, fellas?
Small clarification. They did not report significance in those.
Oh,
in all of those. Yeah. Because remember, the primary outcome is that feasibility, which I really liked about this paper, honestly. Like they really made a point on multiple occasions to kind of say, look, these aren't significant, but we're going to kind of report these percentages, if you will, to give you an idea that, of what things kind of laid out. But
yeah, that note spells up for a bigger trial. Yeah, my bad. Totally missed the boat.
Yeah, it's easy when we're kind of used to all these things being done significantly or reporting significance. So,
well, we did a feasibility trial, one of our first papers in the DoD, and we did the same thing and didn't report significance and just reported trends. And viewer number 2 said the problem with this study is it's not a study.
I mean, that's a problem with literature. Like, I mean, so many researchers don't even know what good research is. It's wild to me, and well, I mean, I think we've all probably been hit up to review papers at this point, and I'm going, I don't know that I'm really like, I can't review the statistics. Like, that ain't my skill, like that. Hopefully your editor's doing that. But yeah, that's pretty funny.
And I guess, we didn't mention it in our course. We talk about one of the first persons who looked at using tourniquets for things was Augustus Beer, German surgeon, late 1800s, started putting tourniquets on, inflating them, deflating them to see if they could help with some conditions. And one of the groups that was looked at in America using the Beer technique was in the early 1900s up in New York with peripheral vascular disease. And they would just put the tourniquets on and off all throughout the day. And these people were able to walk longer without claudication symptoms. They had a remarkable improvement in their healing. Their 6-minute, this is my 1920s voice. Their 6-minute walk time was significantly better.
Oh, God.
The Christians did better than the Jews. Because they did ask you religious. They asked your religious preference.
Oh, seriously?
Yeah.
Oh, no. What in the world?
But we always said, that'll be my last accent I'll use today, fellas. I said, man, that's a badass study in a population that I thought could really benefit from blood flow restriction. would be peripheral vascular disease patients. And so to increase 6-minute walk time as much as they did, their ability to walk without claudication symptoms, reduction in pain, improve their quality of life, all seems like this is moving in the right direction. Again, controls didn't really get an intervention. Maybe you could do high resistance loads with these individuals and would see a difference because this was work matched. But overall, it seems like a good trend. What about not seeing a change in strength or hypertrophy? What are your thoughts on that? Not enough sessions, not enough load, too low of LOP, not
I'm
enough
honestly
capillarization to the muscle fiber, Chris Fry stuff.
That's where I was going.
that was one of the thoughts that I had, but honestly, I'm still kind of surprised because of how untrained this population likely is. I would have thought you would have seen a little bit really in both groups, whether you're doing BFR or not, just because it's
8 weeks.
yeah, I mean,
that's
it's
your
not
other-
that long.
That's your other issue.
Yeah, it's not that long. It's not that high of a frequency, but you're dealing with people that are untrained, so the potential for change is higher.
Yeah.
But yeah,
Well, the
maybe
accumulation
it's
of
the
all of
blood
that
flow.
stuff, like you said. I mean, I go back, Johnny. You kind of cut out a little bit when you were sort of like nod to Chris Fry and our podcast and all that. What you're saying
About Chris Fry's point of not having
Your
enough
point.
capillarization. Yeah, that if the study he did where people that had lower capillarization had less ability to make changes in muscle strength and muscle size over 12 weeks compared to people that had more normal or higher levels of capillarization in older folks. And so the muscle is fed by the capillary beds, and the more capillary beds that you have in those muscle fiber areas, the better they would do. These people probably are really limited in that area.
exactly.
And so
Yep.
it could be kind of what Chris talked about. Over this 6 to 8 weeks, the angiogenic effect kind of brings them to baseline enough that they would another 4 to 6 weeks start to see some changes, just because they did get some increased capillarization.
That's kind of what I was curious about. Is like you just kind of wonder, like, all right, if they had done another 8 weeks, what do you
Right.
see in that time? And you do have accumulation of stuff, like you said. You got the LOP thing, but they also capped the maximum LOP at 220 millimeters of mercury. So they didn't, if your LOP was higher than that, they just said, well, 220 was your max, which of course we know is not going to work for potentially a decent amount of people in this trial.
For me, with my
Yep.
massive tree trunk muscle legs, I'm at
Exactly.
400. So, I would have been screwed. Well, what about mechanisms? If you've listened to our podcast, you probably heard us talk about this, but why would BFR be so beneficial for peripheral vascular disease, all the way from the hypoxic state to turbulent flow to vasodilation?
Yeah, I mean, I think you look at that, and one of the big things, like you guys were just talking about, maybe why they didn't really get the change and whatever, was the lack of perfusion that they had. And then from there, just mechanistically with BFR, one of the big mechanisms that drives the changes through VEGF, or this vascular endothelial growth factor. And what we see from that is a significant upregulation over 5-fold, like 2 hours just post exercise of doing one exercise, leg extensions, compared to no change out of a regular low intensity exercise. And even at that acute marker, there's no real effect even with high load exercise at 2 hours. And then they reassess that, out to say 4 hours, and VEGF's upregulated 6.5-fold. So you get a huge increase in this angiogenic growth factor. And then you take a look and you kind of say, well, what does that acute change ultimately lead to is if we continue this out over a training period. And that's when Jacob Nielsen, you pull his data where he had individuals perform 23 training sessions over 19 days. And he collected biopsies at baseline, the midpoint of training, which was training day 8, and then continued on to 3 days post-exercise, another biopsy, and then 10 days post-exercise. And you could surmise that acute rise in that growth factor led to a 24% increase in capillarity by the 8th training day. So we get a surge in capillary beds, an increase in perfusion, and that ultimately can help. Going back to what we talked about, one of the big issues that you have with people with peripheral vascular disease and their inability to exercise is driven by their inability to perfuse the tissue that's working. And so this might be an avenue there. And then, we talked, kind of hinted early on as well about either this ischemic preconditioning type of an effect, or like the ability to buffer hydrogen a little bit better so you can perform for a longer duration. And that's where some of the work has actually been done within this population, is going through and testing, doing incremental treadmill tests. And it certainly looks like IPC or remote ischemic preconditioning may have an avenue of acutely boosting someone's ability to exercise. Now, what that looks like over a training period, I think is yet to be seen, but acutely, there certainly is an effect there. And just real quick, mechanistically, where that might come in, and what IPC does is it basically conditions cells to be more resilient during a period of prolonged ischemia. And so they can function and better utilize the energy means that are generated from aerobic means with oxygen. They can do that for a little bit better in a prolonged period of time before they transition into that anaerobic environment. And then ultimately, without getting too deep into the weeds, you get this inability to maintain these ion channel pumps that rely on ATP to function. And once that happens, that's when, basically the progression into cell death and all that stuff occurs. But I think mechanistically, that's where things, I think, largely we can have an effect with BFR.
Yeah. Did you guys see I think what it was I wrote down this morning, 2018 study, Annals of Vascular Surgery, where they did a RIPC, and this was in intermittent claudicants, exercise, or RIPC and exercise. And RIPC, they all improved, and there was no difference between the groups. So basically, instead of exercising, if they just RIPC'd, their outcomes were the same as the exercising group after about a month.
Interesting.
It's that's an interesting approach too. So they just came in, I think it was every 3 to 4 days, and did ischemic preconditioning, or they did their strengthening exercises. But the combo didn't improve anything any better.
Well, and the other mechanism, the other mechanism that we didn't really talk about that I typically think of also is the shear stress component, or that change in pressure within the vasculature. And with these things in the population we're talking about, I wonder if some of the effect of these mechanisms is blunted because of the disease state, right? Like, okay, we think about VEGF and HIF1A and these things being regulated by hypoxia. Well, these people are already in kind of a hypoxic state. So I wonder if, same thing from a shear stress component. I wonder if we're not getting as much change because there's not as much compliance in the vascular system. And so maybe there just needs to be, like Kyle was bringing up, maybe it's a longer time frame that we need to really see some of these things. And then also in that position, paper on exercise for claudication, they brought up, you see improvements in exercise capacity and performance without necessarily seeing changes in the vascular system or the ABI, and so maybe those are not, always directly correlated with one another. They probably do have some hand-in-hand function there, but
there's always that piece of, do people just get better at tolerating discomfort?
Right.
That's always like the argument with stretching studies is like, people they didn't actually change the length of the muscle, but they just got better at tolerating that sensation. And so they are able to, stretch a bit farther. Right.
Yeah. So, I mean, I'd be curious to see. I mean, and obviously Annie's stuff goes along with this, and she actually did see some signs of vascular improvement. So it just seems like now the next step is getting studies that actually measure, more of what's changing on the vascular side and what's changing on the functional side. So
that's what I think is badass with all this vascular stuff. It seems like the change happens quicker than I ever would have thought. It's
Yeah, it
you're talking
happens.
like 4 to 8 to 12 weeks. I was thinking like vascular, like, gee, it's going to take like a year for all that stuff to change. And I mean, it's like weeks. It's crazy.
Yeah, it
Faster than
happens
muscle.
pretty
Hmm.
well. Hold that thought a second. Um, Back to what Ben was saying was one of the things I wonder too is if it's like joint OA, and when the joint is so far gone, it's gone. And you can do stem cells, you can do all these great things, but the joint is gone and you're not going to save the joint. And I just wonder too, like, if you take a look and if you can stratify people based off of whether it's ABI or their ability, their incremental treadmill testing, and then say like and start grading people on a scale and saying like, oh, these are the people that are the initial onset of the disease. We can have a really good effect with them with this treatment versus when people are at the end. We just may not get the change that we think we potentially might.
Yeah, I see where you're coming from, Zach. There, I think the only kind of caveat to that is, um, like we know the vascular system has regenerative capability to kind of regenerate itself back to normal versus like I remember when Johnny, first kind of came out our way and was teaching taught us BFR. That was kind of one of the points he would make with regard to muscle scarring down. It's like it scars down, but it doesn't actually necessarily fully regenerate, and you have those TGF beta pathways that kind of jump in where like if the same thing happened in your stomach or the lining of your intestine and you got a little nick and these scar pathways jumped into action, that'd be deadly and problematic. But we have these stem cells that can kind of come in and repair and regenerate. So you gotta, I mean, it's certainly a possibility, but I also think, all right, but we do know that the vascular system can at least kind of repair and regenerate itself better than other structures, like a joint surface, for
Yeah.
example.
It makes evolutionary sense for sure.
Yeah.
That vascular,
Yeah,
like even John Craig used to talk about the collateralization that can happen can be rapid as well.
Yeah.
So it's
There's an
interesting
IPC study showing that.
Yeah, maybe they just start to build up these collaterals when they hit a dead end.
Definitely.
The other thing that I was going to say on these muscle changes and vascular changes, I really think they go hand in hand, and I would maybe even speculate that vascular change is what drives the muscle change. You kind of hinted on it with Chris Fry's stuff, but man, there's ton of muscle stem cell research, or not tons, but there's more than one paper out there that has looked at muscle stem cells and capillary beds. And the muscle stem cells that are closest to the capillary beds, whether we're talking old people or we're talking young people, those are the ones that activate and proliferate. And then you take a look at Jacob Nielsen's stuff, the increase in capillarity. Training day 8 was the first time it was tested, 24% increase in capillarity. And then you have a 293% increase in PAC7 or muscle stem cells in type 1, type 2 fibers. So that and then then you can take a look. Other papers have looked at the relationship between muscle stem cells and muscle hypertrophy. Roughly 49-50% of the variance in muscle hypertrophy is driven by muscle stem cell content. So I think like that's the deal.
Yeah. I don't know if y'all remember me talking about Josh Winke at the ISR. He was it's all about the capillary beds that's where the stem cells live.
That's
Stem
it.
cells live in the capillary beds. But again, it's just like mechanistically, that's like one of the biggest no-does with BFR. And that we can move that needle so rapidly. It's like, man, this is something. If you have vascular clinics out there, will someone start treating patients with this and let me know how it goes so we don't have to wait a multi-center trial? Because I would love to just have a vascular clinic with a freaking leg press and a treadmill and some BFR, some Delphi systems in there, and just do these little interventions. I just feel like there's potential. Well, on that point, would y'all go at it differently from aerobic, have them do like a walk program or bike versus resistance? we've seen that in different styles of the studies. Because there's that Benson, I don't know if y'all saw that case series where they did walking, and they had similar results, and ABI increased as well, ankle brachial index.
They just did one leg.
But they did 12 weeks instead of 8 weeks. So it was longer.
At 4 times a week, which I mean, I think we would expect you would have to do that, to kind of get similar results.
I think it's 4 times a week. They do 4 times a week because it was a European study and they all take off on Fridays and don't do shit.
Hey, we could learn from that.
They did it in the summer when nobody's working at all.
Yeah.
Every time I email people from there, they're always out. Luke Hughes, Stephen Patterson.
Yeah, hashtag Luke, hashtag Stephen.
Apparently out of the office.
I don't know. From a vascular standpoint, my brain kind of does go a little bit more toward the aerobic or endurance-based activities, just because we see more of those doing a bilateral, and we see more of those doing a longer duration under hypoxia, which in my mind would be a bigger stimulus on the vascular system. Whether or not we actually see more vascular change, I don't think we really know that conclusively. But I mean, from a logical standpoint, it makes some sense. So
I think you just have to figure out what a person can do.
Yeah.
I mean, in the end, Johnny, back to your kind of original question there, what would you do? That would be my thought is, well, let me just find out what can this person do, but maybe more importantly, what can I get them to do? And that's why it's like I keep kind of mentioning this IPC thing, because I envision, as a clinician, somebody comes in your clinic and you're like, oh, let's try this BFR thing, but you can't figure out where to start because the person's so limited. And it's like, well, maybe you can just teach them to get comfortable to the cuff being on them, and once the cuff's on them, you can always have them clench their muscle a little bit. You could have them move there's loads of things that, you could kind of try, and still be able to grade with regard to the occlusion pressure or the activity that you're giving that individual, until you get them to a point where it's like walking on a treadmill or exercise or something like that.
Maybe I haven't seen it, but it feels like this would be an interesting study. So you IPC, and we know that you get an increase in bradykinin and adenosine. So you get this vasodilation effect just from IPC. And so we see some of the IPC, you do a pre-performance, you see performance improvements from that vasodilation. Just with an IPC patient, a peripheral vascular disease patient, IPC them, then have them go walk and increase their ability just to walk from that. I mean, that's an easy protocol. And there's already a Medicare code for walking with these people.
So that's what this paper by Sayes did.
Yeah.
They tested that, Johnny.
It's fine shit. That was my idea for a drill study.
Well, sorry. I mean, maybe you could replicate it. But no, that's so crazy enough. Like that's what they ended up doing was they separated individuals into 3 different groups and just did incremental treadmill testing under 3 different conditions. So they walked on a treadmill first, and then they brought them back like a week or so later, I believe. And then they had them do remote IPC, and then walk again and look at the distance at which they walked. The second group did RIPC first during the first session, walked, and then came back a week later and then just walked again. And then the third and final group straight up just walked on the treadmill regularly each session. Just to look at basically, is there some sort of training effect going on? So basically, are people just getting better on the second session, regardless of what's done? So
this was with peripheral vascular disease?
Peripheral vascular disease, yeah. And so the treadmill test was walking at 3.2 kilometers per hour, whatever that translates to in miles per hour. But and then
no idea.
the treadmill was increased 2% every 2 minutes until that person said they tapped out and said, I'm done. Outcome measure that they looked at was the initial claudication distance. So like when they started to feel their symptoms, and then the total distance that they were able to walk. RIPC was your standard 5 minutes of ischemia, 5 minutes reperfusion, cycled 3 total times. This was done in the upper extremity, and it was done 90 minutes before the treadmill testing. From here, so this is just an acute deal, and then what they found was there was a significant increase in the first group that did the RIPC treadmill second. There was a significant increase in that distance walked. The second group that did their RIPC treadmill test first, they walked for a significantly greater distance that session than what they did the second session. Now, there was a little bit of a training effect in that everybody, or the group C, did increase the distance that they walked over the second session, but it wasn't or the group A that did RIPC second walked a significantly greater distance than what group C did in that in their second session. So what we're getting at, or what this ultimately goes to show, was RIPC, it appears to have an effect. We see that when RIPC is performed with that treadmill walking, they're able to walk for a greater distance prior to the onset of symptoms.
So if we were to build a hierarchy of how to approach patients from the absolute most limited scenario up to resistance exercise loaded at, say, a 30%, 1 rep max, how would y'all split that up, do you think? How would you approach it?
So real quick, and I'll tie that in with what Ben was saying before, and with maybe this avenue with RIPC or IPC. I think one of the key factors is the sheer stress on the vessel wall, and it's the inflation and deflations. I think is a big player here. If you remember the paper from Danny Christensen, when he was looking at like glute forward transporters and all that stuff, he had a straight up hypoxia group that was just breathing like hypoxic air. I believe it was like 9% or something, maybe 12% oxygen. Either way, what happens is it was the group that was cycling with the tourniquets on that has the greater glute forward migration to the cell wall. And so what I'm getting at is hypoxia itself does not explain that change. It was the sheer stress on that vessel wall that, and believed to be the inflation deflations. So maybe the avenue.
So a function of the vasodilation that you're going to get, which one of those IPC studies showed actually, like they IPC'd one arm, but you got vasodilation in the contralateral limb that wasn't even
right. So,
so which is interesting to kind of think about.
Yeah.
That was my new slide. So.
Driven by like endothelial nitric oxide and such. And so I think maybe the hierarchy and how we would manage a patient with this situation, see what they can do, like you guys said. But then if they're really limited, we just go through alternate inflation deflation if they don't tolerate the aerobic exercise or right away or at all. And then I think doing a few exercises, resistance exercises with the cuff on. And that way, if you do the IPC, you're getting 3 rounds of inflation deflation. And then if you can target 3 to 4 exercises, that's another 3-4 inflation deflations. And you should be
inflation deflation, Zach, but let's be specific here: arm, leg, percentage of occlusion pressure, etc.
Yeah, I think LOP is interesting for this.
Yeah, I mean, I think I would try to target in the leg the higher pressure, and that goes back to the Mauser paper, and what they found was 80% limb occlusion pressure produced the changes that the lower limb occlusion pressure did not change. So I would try is the key word when you manage the patient, but I would try to have a higher pressure in the cuff. Now, if that wasn't tolerable or whatnot, and then we can kind of reduce it down from there.
Yeah, I think so. Like stick to our same guidelines. If they don't tolerate it, go lower, because a lot of these papers are using like 50, 60 LOP, but it's just, I think they're nervous to go higher. And when you set up a study, you don't want to screw yourself and
Right, and have a high dropout.
Can't tolerate it. It doesn't mean 80% wouldn't do better. It's just, you got to make sure they tolerate it.
And going back to your question, Kyle, of hierarchy and how would you, implement, it seems like starting with the passive inflation deflation, like we've talked about, is the place to start and know that it's going to be easier to tolerate it. And I mean, going back to what we discussed in the history of BFR, and we kind of alluded to early on, of just passive inflation deflation, improving walking tolerance and pain and wound healing and all that, they were doing a pretty low pressure for a very short amount of time. They were using 80 millimeters of mercury for 2 minutes on, 2 minutes off. But they did it for a long duration. It was like 12 hours a day. So maybe that's the give here, is you could either maybe push for a little higher pressure, have less, inflations and deflations, get it done in a shorter amount of time. Or if you need to go lower pressure, you probably need to take this and spread it out over a longer time in a treatment session, And so that seems to be the give, at least from the limited information we have. And maybe, especially in this population, maybe starting with BFR on the upper extremity, because it's not where they typically have their exercise symptoms. Maybe that would be a way to introduce it and have them tolerate it, experience it, and then we transition to the lower extremities. And we could do something like, recumbent cycling or walking. Start with a lower pressure to introduce it, make them comfortable, do it in an intermittent fashion. So again, it kind of makes it something that's more tolerable. Maybe we start with something like 50% occlusion, like the Parkinson study did, and then work our way up. So
Ben, you were talking about that 1920s paper that I mentioned earlier.
Yeah.
Because they also found that 5 out of the 7 patients made it to the cafeteria and could get a sarsaparilla. One patient remarkably was able to.
Sorry, your internet's cutting out, Johnny.
Patients recounted their time fighting in Napoleonic Wars.
Oh my word. Somebody else has joined the chat, apparently.
Lots of potential here. Lots of Not with that. No, I'm saying with the study, not with my 1920s accent. So man, I hope these guys get a multi-center. It sounds like what they're going for over there. I don't know. Do you guys know these folks at all? I have to reach out. See if Luke and them know.
I didn't.
No.
Okay.
No.
Well, I think the potential is huge for this. Really easy to do. And if we're improving people's vascular systems, that's a big game changer. And then hopefully we can throw some strength and hypertrophy on there. My granddad had peripheral vascular disease. It's miserable, man, because he was a real active dude, and he would just work for a few minutes and have to stop and put his legs up, rub his legs, rub castor oil on, whatever the heck he would do to try and get better. But it's a miserable way to live, especially if you're trying to do a lot of things. Cool. Anything else you guys want to add? I know Kyle said we got a bunch of
we do have some questions. I was just going to say that the one thing I don't think we really discussed with regard to not seeing increases in strength or hypertrophy is they estimated a 1 rep max, but I didn't have, and they reassessed it every 2 weeks. But I didn't have the image that they said described how they estimated it. So we don't really know if they truly were like really close to like a 20% of 1 rep max or not, depending on how they estimated it.
It seemed they made some mention to RPE, but I don't know if that's how they estimated the rep max.
They
Yeah, I
they
don't
did
know.
it based off failure.
Hmm.
They did
Yeah,
using
but with how many
repetitions.
reps?
But the big problem
That
was
was the
something
thing.
like, well, the problem though is they cited another paper they did.
Hmm.
Yeah, I
Um,
think they said
dude,
previous
Yeah.
study.
yeah, the problem that you run into with stuff like that is when you're doing when you're basing your rep max on a high number, it's just going to really
That's my
influence.
point.
Yeah.
This is the
The
point I'm
the
making,
other
Zach.
thing with that too, Kyle, was I think they did the traditional set of 33 15s on the leg press, but only three sets of 15 on the leg extensions. I think it was the
I
protocol.
wrote that they did all 75 reps, but I definitely could have missed that. Sometimes these things hide.
Yeah,
Yes.
no.
Patients perform 4 sets of 30, 315s for the leg press, followed by 3 sets of 15 repetitions for the knee extensions at 20% 1 RM. So,
Yeah.
maybe
So maybe a
that
volume
was,
thing there.
well,
Yeah.
and then when you're trying to assess, you're only doing 45 reps and the exercise that you're, looking for.
There's another study that did something very similar to that. I think it was like that Abe paper or something way back in the day. But anyway,
Yeah, but that was their test, was leg extension strength as well as vastus lateralis. So if you're only doing those 3 sets, it might not be enough volume.
So
And it's the
Kyle,
hardest thing with all these PFR studies. Like, how many of those subjects actually even completed that volume? I know from
Yeah.
ours, it's like, and we did 30, 15, 15, 15. Yeah, it's like, yeah, not for the first couple weeks.
Yeah.
So Kyle, they used the Brzezicki formula is what they
Okay.
based it off of. But
Yeah. So
again,
they use a formula, but you still don't know how many reps they did, right?
well,
How are you going to report that?
it was to failure. So, the problem is you don't know what the load was. You know what I mean? So
Well, my
also
point
don't.
is like you're gonna. I mean, if you're failing at around 10 reps, that's around about a 70% one rep max. But that's the predictive value of those things. Is like if you can do more than 10 reps, they lose accuracy. So if they were doing like a 15 rep max or a 20 rep max, plugging into the formula, that is not going to be as accurate as if they had done like a 5 rep.
Half the papers don't tell us how they get their 1RMs, really.
Yeah.
Yeah, so they increase. This is the other paper they did increase until momentary muscle failure occurred within 10 reps.
Okay.
And so you just don't know, but
You
But
think
they used it
did
appropriately, is
they
the
did the
answer.
Brzezicki formula, like did all the divisions themselves, or just use an app? That
you know what?
was a bitch.
There's way that fucking I'm sorry, that freaking formula. Go ahead and edit that out.
No, oh no, that's staying in there, baby.
Explicit. Yeah.
Dude, that formula has way too much math in it. All you got to
Yes.
do is the load times the max number of reps multiplied by 0.033333 repeating and add the load back in. Dude, it flows in the calculator on your phone. Simple. And
That's
yeah,
why people use that Brzezicki formula.
I don't know.
Ridiculous. Like,
Yeah,
that's like calculus to me.
Yeah,
and all it has is some division. Once you start putting some parentheses around the numbers, I'm screwed.
Yeah, it's like, dude, who has an Excel spreadsheet pulled up that you're just gonna plug? Dude, just make it simple.
App.
Or use the 1RM calculator.
The app. Yeah, use the app.
All right, man. Again, good stuff. Hope we get more of this. And if anyone is doing this with patients out there, please let us know. I'd be very interested to see real life kind of how this is going.
Yeah.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.
One last thing before we get out of here. First, want to say a sincere thank you for listening all the way through, but also wanted to remind you that this podcast should not be considered medical advice. It is strictly entertainment. It's a way for us to try to keep up with what is ongoing within the BFR world. If you require some sort of medical attention, medical advice, please seek that from a licensed individual within your state. Thanks, and we'll talk to you soon.